Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who has to attend every 6 to 9 months on average, and they, as you can see, develop really impacted and blocked earwax bilaterally. And I'm just commencing with this their left ear, and I'm just using a Jobson horn. We're going to try and remove all of this wax without introducing any microsuction. And that's for the reason that on occasions in the past, the patient has developed what we call a temporary threshold shift. So we call it a TTS. And that can be caused sometimes when you perform microsuction. Microsuction can be a bit noisy, noisier than what most people anticipate it to be. And exposure to loud sounds can lead to a temporary threshold shift, so a temporary reduction in your hearing. On very, very rare occasions, and touch wood, it's not happened to me before, and hopefully it won't, but you can also develop a permanent threshold shift, and that's when you develop a permanent hearing loss after undergoing microsuction. Now, these are very, very rare instances, but in the past, the patient has developed, for just a few hours, a temporary threshold shift, and so on this occasion, because the wax is a bit firmer, I'm able to use dry instruments. Previously, the patient used to use drops in their ears and the wax was really wet and gooey. It was just impossible for me to remove using a correct or an ear hook or forceps, for example. So I've had no option in the past but to use suction. I would say that when using dry instruments, it can be on occasion a bit more challenging because you're more likely to come in contact with the canal walls, whereas with suction, because you're vacuuming earwax, you can sometimes avoid making or ensure that the suction probe is not in close proximity to the canal walls, whereas with forceps or ear hooks and Jobson horns, you don't have that same luxury because you're sometimes having to manipulate the wax off the canal wall. If you're working on the outer third, like we are here, then this is the cartilaginous portion of the ear canal. So this portion of the ear canal contains a thick layer of skin. It's about 1 millimeter in thickness, and the cartilage is malleable. So it's not rigid like the inner 2/3. So whenever you're using instrumentation like this on the inner 2/3, when we're just on the boundary here, so to the left, that's the second bend, and beyond that point, the ear canal is made up of bone, and anything in front of that piece of cartilage, so where we are now, this is the cartilage. The bony part of the ear canal is very sensitive and very delicate. The skin that lines the bony part is extremely thin. It's less than 0.1 millimeters in thickness, and we don't want to cause any trauma to that skin, because if you do, you give rise to the patient not only experiencing earache, what we call otalgia, and trauma as a result, but you run the risk of the patient developing an infection, because that skin provides a protective barrier to harmful pathogens. So it protects the ear canal itself, and if you cause trauma to that skin and that barrier is no longer there, or it's less effective, bacteria can then seep in and cause riot. So fortunately with this patient, we were able to remove the whole occlusion using the correct. You may have noticed in their left ear that there was a bit of scar tissue, what we call tympanosclerosis, at the inferior part of the eardrum, so the lowest section of the eardrum. And that's a calcification of the middle membrane of the eardrum. People develop tympanosclerosis for many different reasons. It could be acoustic trauma, so exposure to a really loud sound, or even moderately loud sounds over a prolonged period of time. It could be physical trauma, so injury. It could be due to chronic ear infections. It could be due to surgeries. So for example, a lot of patients who have grommets fitted, so ventilation tubes, once the grommet has fallen out and migrated out of the ear or been extracted out of the ear, the eardrum heals itself, and sometimes you just get a bit of scar tissue there. Just simple aging process over the years can cause it. Barotrauma, so a barotrauma is a pressure change. It could be either in the air, so a sudden descent or elevation in an aircraft, for example, or for example, if you go scuba diving and you suddenly go deep into the water, These are all potential reasons. Now, this patient did have grommets fitted as a child. On this, their right side, the occlusion's almost removed, and you will see the eardrum a bit in a moment or two. And although there's no real prominent tympanosclerosis scar tissue, there is evidence of a healed perforation, so that's likely to be where the grommet was inserted. This ear for the patient, the right ear was a bit more narrower, and as we enter the ear canal on the left, so posterior, there's a bit of a blind spot here, so there's quite a big buildup of wax in this region that it's not always. If I was using a microscope, for example, or the wax scope, which is the other device that I developed, and if you want to see videos using the wax scope, there's a link there in the description to visit our ClearWax YouTube channel, where you can see some videos taken with a wax scope. Sometimes it can go, all this could be missing. You can inadvertently not notice this, partly because with an endoscope the view's so much more wider. We get a really wide parallel field of view in comparison to an otoscope or a microscope. In addition, when you insert a speculum in the ear to stretch and straighten the ear canal, that blind spot can be blocked away. It could be hidden by the speculum itself because the speculum will rest up against it. So I was quite surprised how much wax was here. I mean, we're almost done in removing all this wax behind the entrance. There is some wax on mid-canal, as you can see there, and I did just explain to the patient that it's non-significant, it's not going to affect the hearing, but they just wished for it to be removed because they do attend on a regular basis. And I said, because it's mid-canal, it can be slightly sensitive, so we will attempt to remove that. If we were using suction, I probably would have found that a bit easier to remove because you can just hover over it. And that's what I was alluding to before. With suction, sometimes you can hover over the wax without making contact with the wax initially or the canal wall. When you're using instrumentation like this, you're more likely to make contact because you do have to approach the canal wall. So you can see here, I'm just stretching the ear open, just entering, and I'm just going to hover over the top. I'm just gliding this into the cartilage portion, so it's now off the bony part. It's in the cartilage portion, what I call more of the safer zone. You can see how thin that sheet of wax and keratin was. So now we're back on the cartilage region. I'm just going to use the Jobson horn to remove this. You can tell the difference between the bony and cartilaginous portion. The cartilage portion's a bit more paler, whereas the bony portion, because the skin's a lot narrower, it becomes more redder in appearance. It's probably more glossy as well, the bony part of the ear canal, whereas the cartilage portion is more of a matte finish. That's the patient's eardrum. Just inferiorly, there's a little evidence of a little circle there, previous perforation caused by grommet. I just took this photo of all the wax from the front on angle. You see it's quite a substantial amount that we removed. And this is a bird's eye view of the majority of the wax. There's still a lot of wax at the bottom of the tissue, but if I got that in view as well, then it'll just be too far away. It wouldn't be zoomed in enough, and it's not really a very good photo if that was the case. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.